Good morning. I'm Stephanie Coulter, and I'm the Director for the Women's Heart and Vascular Health Center at the Texas Heart Institute. And I'm going to speak today on exercise fitness and cardiovascular disease. So first we're going to define some important characteristics. So one, physical activity. Now, physical activity can be any type of movement produced by the contraction of the skeletal muscles that increases energy expenditure above the basal level. It can be occupational, it could be household, it could be leisurely, and it can be involved in how you transport yourself around the neighborhood and to work. 19% of females and 26% of males meet criteria for sufficient physical activity. Clearly, we are deficient. Exercise is defined as a planned, structured, repetitive, and purposeful physical activity to improve or maintain physical fitness. Now, exercise can be in lots of ways. You can do aerobic or endurance exercise, which is designed to increase cardiovascular and respiratory fitness, such as walking and running. Strength or resistance exercises are designed to increase muscular strength, such as weightlifting or body weight resistant exercises. Balance exercise is designed to improve balance and proprioception and to prevent falls, such as heel-toe walking or Tai Chi. There's also mobility or flexibility exercises intended to maintain or improve range of motion around a joint or to lengthen a muscle or joint. And those are like yoga or even Pilates. Inactivity is defined as really inactive, okay? And this is included in about a quarter of all adults worldwide are physically inactive. And this percentage is increasing, particularly so in developed countries, in women with increasing age, and in lower income groups. Sedentary behavior is defined as sitting for greater than 8 hours a day. About a quarter of U.S. adults are sedentary, and this is increasing. In developed countries, only 13 to 34% of primary care patients reported having received any advice on physical activity from their primary care clinician. You can see that from these definitions of activity, people can be in multiple categories. So you can be sedentary all day and then get out and run 8 miles. So there may be some shifting between the categories, but these are the definitions that are used to define activity as we proceed through this discussion. So exercise intensity is another way we measure exercise, and one way is to look at the training heart rate. And training heart rate tracks the linear relationship between heart rate and oxygen consumption. So the higher your heart rate with the exercise, the more you're consuming oxygen, the more intense the workout, okay? You can have a ratings perceived exertion score, which we use when we do stress tests in the office or in the hospital. It's also called the Borg scale, and it starts at 6, which is kind of a funny way to start a scale. And the reason is because light exercise perception is less than 12, which corresponds to a heart rate of less than 120. So in fact, whatever the Borg or RPE scale is, to make it into heart rate, you just add a 0. So for moderate exertion, it's 12 to 13 scale, or a heart rate of 120 to 130 while you're exercising. And for intense exertion, it's 14 to 16, or a heart rate of 140 to 160. So it's a way to track how well you're exercising. The most specific way in science we can measure intensity is the metabolic equivalent. The metabolic equivalent, the MET, is really the ratio of the MVO2, or the maximum oxygen consumption during an activity, compared to basal oxygen consumption at rest. At rest, this number is about 3.5 milliliters per kilogram per minute, and that's the equivalent of 1 metabolic equivalent. And activity is rated as 2 METs would require twice the VO2 that occurs at rest. And a more interesting and kind of current way of easily measuring exercise intensity may be the rate at which you make your steps, okay, which can be tracked on a wearable device. So what about physical fitness and intensity? Physical fitness and intensity are related. So in fact, a set of somatic attributes brought about by engaging in regular activity that allows one to perform vigorous tasks without undue fatigue is the real definition of fitness. But really, fitness comes in two flavors. There's either cardiovascular fitness or muscular fitness, where you can be a skinny marathon runner and have absolutely great cardiovascular endurance, but your muscular strength isn't so great, okay? We like to measure cardiovascular endurance because it is actually that ability to supply fuel and eliminate metabolic byproducts during moderate to high intensity exercise via the cardiovascular and respiratory systems. The duration of exercise and the maximum oxygen uptake on a treadmill compared with age and sex specific normal values is how it's measured. And this number has been associated with a reduction in cardiovascular risk and overall cardiovascular mortality. So it's been well studied, and it's going to be the subject of what we're going to speak about soon. But muscular strength refers to the body's ability to exert force against an external resistance. So here is a chart that we use actually to estimate what the physical expenditure of energy is in metabolic equivalents for routine kind of activities. So you can see that high intense activity such as running, so if you can run a 6-minute mile, you're expending over 16 metabolic equivalents while you're doing that, which is kind of near the maximum being close to 20. But if you're just playing bowling, which is only 2 to 4 metabolic equivalents, or cycling on a hill, it may be 7. So you can see this is just a table getting an estimation of what those physical activities mean for physical work. So exercise intensity can be classified as light, moderate, vigorous, and near maximum. And here are the scales. So lightweight would be really at about 30 to 40% of your MVO2, would be about 2 to 3 METs, or a Borg score of 9 to 11. Moderate would be 40 to 60, vigorous would be 60 to 90, and near maximum is near 90%, 14 to 20 metabolic equivalents, and a Borg score of 18 to 20. Evidence for exercise and cardiovascular events is actually really hard to get, okay? And there are a lot of reasons for this. One, exercise is hard to measure, so the behaviors are hard to measure. In fact, if you do surveys of patients who exercise, it's really difficult because people don't tell the truth. People that exercise a lot tend to underestimate how much they exercise because they don't think they're doing enough. And people that don't exercise at all think they're doing more and overestimate how much activity they're doing when asked on a survey. When you try to do a randomized control trial, it's very difficult because it's hard to exclude patients in the control group from exercise. So in fact, anybody enrolled in a clinical trial that knows they're being assessed for their activity, they start exercising more in the control group. And in the group that's in the activity part of the group, they lose their drive to exercise and become less compliant as the study progresses. So we're really served with looking at observational long-term cohorts, which use self-reported exercise, which use wearables, and also have a healthy bias within them. So what are some of the possible biological mechanisms for exercise-induced reduction in cardiac risk? Well, exercise improves nearly everything we measure as a cardiovascular risk factor. It improves the blood pressure, it improves the lipids, it improves the insulin resistance, it improves peripheral vascular tone, it changes the fibrinolytic system, it changes the endothelium-dependent mechanisms for vasodilatation, it changes upregulation of some genes, it reduces inflammation. And in fact, cardiovascular fitness was measured in 5,000 18 to 30-year-olds, and they found that kids in this group that exercised well had at 15-year follow-up much less new onset diabetes, hypertension, metabolic syndrome compared to the group that didn't exercise. They also showed in this study that these youngsters who had low fitness had 3 to 6 times the likelihood to develop diabetes, hypertension, and metabolic syndrome than those who were in the high fitness group, suggesting that activity when you're young really protects you 15 years out. So there are lifestyle factors that affect survival, and you can see in this study that looked at exercise, cessation of smoking, reduction in hypertension, diabetes, that in fact exercise and smoking cessation had the biggest impact on survival in follow-up. So here's some of the data for exercise in the primary prevention of cardiovascular disease. And first we looked at the prevention of heart attacks in the InterHeart database, and physical activity decreased the risk of first MI by 14%. That's pretty good. In men, they've been followed in 3 pretty large cohorts for very long follow-up periods. So the Harvard alumni looked at 10,269 men and followed for 12 years, and they looked at men who reported moderate activity of 30 minutes daily, and at 12-year follow-up there was a 23% risk reduction in death. In the Honolulu Heart Program, another 707 men, average age 69, who were involved in low-intensity daily activity, including walking 2 to 8 miles. Those patients had a 23.8% reduction in adjusted mortality compared to those that didn't exercise at 12 years. Again, another study showed that 7,337 men aged 66 that were involved in moderate or strong intense exercise compared to those that had weaker, less intense exercise over 5 years had a risk reduction of 34 to 28%, which is pretty significant. And again, in women, 2 long-term cohorts of healthy women, the Nurses' Health Study and the Women's Health Initiative, looked at their data in over 70,000 women aged 40 to 65, showed that increasing intensity quartiles of exercise had an inverse risk for coronary events. The numbers are on the screen over 8 years, published in the New England Journal in 1999. The Women's Health Initiative again looked at 73,000 postmenopausal women and compared those that had prolonged sitting to those that didn't, showed an increased cardiovascular event. There was also an inverse gradient between the total MET score, which talks about the intensity of exercise, and the risk of cardiovascular events. And similar risks were shown for race, age, and body mass index. So it didn't matter how old you were, what race you were, or how large you were, everyone benefits from exercise. In a twin study in Finland, 8,000 same-sex twin pairs, odds reduction of 0.66 for death in occasional exercisers, but 0.44 in conditioning exercisers compared to their sedentary twins. So certainly the observational data shows that exercise long-term benefits cardiovascular risk for primary prevention. What about physical activity types and the reduction in cardiovascular events? In the Health Professionals Follow-Up Study, they enrolled and followed 44,000 men for 12 years, average age 40 to 75. They had 475,000 patient years of follow-up. And they found that running for an hour per week reduced the risk of cardiovascular events. Rowing for 1 hour or more a week, again, reduced risk of cardiovascular events. Brisk walking for 30 minutes or more a day, 28% reduction in risk. And even lifting weights for 30 minutes or more per week had a reduction in cardiovascular events. When they looked at the intensity of how hard people were working, so moderately intense, 4 to 6 METs had a reduction in event rate. Higher intensity metabolic activities, 6 to 12, had a greater reduction in cardiovascular events compared to low intensity performers less than 4 metabolic equivalents. In fact, a half hour of walking briskly or more a day was associated with an 18% risk reduction in death due to heart disease. The walking pace was associated with reduced cardiovascular risk independent of the number of walking hours. So certainly, this long-term follow-up of a lot of people showed that every kind of activity they measured and at increasing intensity showed increasing benefit. The Steps for Health Collaborative is an important study that was produced this year, and it was actually a prospective study of the association of daily steps with the development of cardiovascular disease. It was actually a meta-analysis of 8 studies, including over 20,000 patients, and looked at fatal, non-fatal MI, stroke, and heart failure events in 6.2 years of follow-up. The study included 50% women with a mean age of 63 years. They found that a step count over 6,000 a day was associated with a decrease in cardiovascular disease risk of 40 to 50% among adults over age 60. Here are the studies that were included in the meta-analysis, and you can see there were 3 that were published studies, and then there were another 5 that were unpublished but were in communication with the authors of this study. The baseline characteristics are shown here, but importantly, here's what the slope of the curves looks like for steps per day versus the hazard ratio. And you can see that in the age group of less than 60, which is on the top, and the late age group over 60 on the bottom, there was a pretty dramatic steep decline in risk early on, with steps starting at as low as 1 to 4,000 a day. So early, if you take somebody who's very sedentary and you get them walking even a small number of steps per day, you can improve their outcome. It was important to show that the group that was over age 60 had the most risk, therefore they derived the most benefit, and older adults continued to accrue benefit with increasing step counts after 6,000 steps per day. So in fact, older adults had a decrease in cardiovascular risk of 40 to 50% with step counts above 6,000. There was no benefit in adults under 60, but that's because the follow-up time was short and there were too few events in this group because they were healthy. So what about the benefits of true cardiovascular fitness? So in fact, fitness is intense exercise that improves the cardiovascular endurance. And clearly in men and women, there have been, I've produced here 3 big studies on this subject, but they all show an inverse relationship between the level of fitness and mortality. So in men, an observational Veterans Affairs study looked at 8,000 men, average age 58 years, with negative stress tests at baseline and followed for 10.8 years. If the stress test, in the stress test, they defined the metabolic peak that was associated with no increase in all-cause mortality, and they made this the reference group. And then they compared those that were less fit, or 2 metabolic categories below the threshold, as least fit, and they had an increased mortality compared to the reference group of 52%. In those that had low fitness, which were 0 to 2 metabolic equivalents below the threshold, they had a 21% increase in risk. Those that were moderately fit, or those that had 0 to 2 mets above the threshold, they had a decrease in their hazard ratio such that 29% had less events. People that were fit had 2 to 4 mets above the threshold, hazard ratio of 0.62, and those that were most fit had a hazard ratio of showing 0.46, which is a 54% reduction in risk. For each additional met in exercise capacity, mortality risk was decreased by 12%, which suggests that fitness actually really matters. This study also helped to assess an age-specific exercise threshold for fitness. So for those youngsters under 50, 8 to 9 metabolic equivalents were the goal. At age 50 to 59, it's only 7 to 8. 60 to 69, it drops to 6 to 7. And age 70, If you can do 5 to 6 METs, you're in shape. In women, a research clinic study looking at about 3,000 women who were asymptomatic and average age of 47 with a negative stress test had 20 years of follow-up. Age-adjusted hazard ratio for cardiovascular death, for every MET decrement in exercise capacity, there was a hazard ratio of 1.2, or a 20% excess risk for every 1 MET that you're not in shape. For every 10 beats per minute of decrement in heart rate recovery, which is a modifier or a way of describing how in shape you are, there was a 36% increased risk of cardiovascular events. Below the median for both exercise capacity and heart rate recovery, women that were below this line had a 3.5-fold increased risk of cardiovascular death with a p-value of 0.002. For women that were in the low Framingham score for risk, these women that had below median levels of both exercise capacity and heart rate recovery had significantly increased risk of cardiovascular death with a hazard ratio of almost 13. So the point being is that if you think you're low risk because you're in the Framingham risk score low, probably because you're young, if you're not in shape or have good cardiovascular fitness, you're at increased risk for cardiovascular death long term. And finally, the St. James Women Take Heart Project looked at nearly 6,000 women and predicted exercise capacity in METs. And they came up with a formula, 14.7 minus 0.13 times the age. And they found that women who achieved less than 85% of age predicted value, that the hazard ratio was 2 for all-cause mortality and 2.44 for cardiac mortality in asymptomatic women. In symptomatic women, hazard ratios were 2.3 for all-cause and 2 for cardiac mortality, suggesting that fitness clearly affects outcome. So what did the ACC and the AHA say about primary prevention of cardiovascular disease? Well, they've been recommending at least 150 minutes of moderate intensity physical activity per week, or at least 75 minutes of vigorous, intense physical activity per week in order to reduce the risk of atherosclerotic cardiovascular disease. If those that are unable to meet this minimum physical activity recommendation, it is recommending that doing at least some of the moderate or vigorous intensity activity is beneficial to reducing cardiovascular risk. In fact, in America, most adults in the U.S. today spend on average greater than 7 hours a day sedentary. So the final recommendation is that decreasing sedentary time and replacing it with other physical activity is recommended. But remember, even a small amount of exercise is better than no exercise at all. This is a health screening process that's recommended for patients wishing to participate in exercise, and I'm not going to go through it. But basically, there's an algorithm that's been recommended to get people that are low risk up and moving as soon as possible. And those that are in the higher risk groups may need to see a physician before they engage in vigorous physical activity. But the risk of vigorous physical activity is exceptionally low. So what about exercise benefit and secondary prevention? So this brings us to cardiac rehabilitation. A large meta-analysis of 20,000 plus patients in 2005 showed that there was a reduced all-cause mortality of 6.2 versus 9% in those that undergo cardiac rehab after an acute coronary syndrome. The overall mortality benefit from cardiac rehab was present at 2 years, but not at 1 year, suggesting that exercise accrues benefit over time. There was almost a significant reduction in recurrent MI at 1 year. Exercise rehab also involved, in addition with risk factor education, they can be combined, obviously, showed a significant reduction in recurrent MI at 1 year. So the ACC-AHA guideline for the management of patients with chronic stable coronary disease since 2002 has recommended that patients' risk should be assessed with a physical activity history and in some cases an exercise test. For patients that are stable after an acute coronary syndrome without revascularization, the guidelines suggest that an exercise test should be performed before discharge, a submax exercise test, or early after discharge, a symptom-limited exercise test, or late after discharge, a symptom-limited exercise test if early exercise was submaximal. In the absence of a contraindication, moderate intense aerobic activity is recommended for 30 to 60 minutes, 5 to 7 days a week. Physical activity to include resistance training on 2 days a week was given a weaker recommendation. Risk of exercise really includes musculoskeletal injuries. Cardiovascular risk is exceptionally small. There's a small 1 in 1.5 million risk of sudden death with vigorous activity, but the risk of arrhythmia, myocardial infarction, and rhabdomyolysis is exceptionally small. Overall, we conclude that exercise is beneficial for those who are at risk for cardiovascular disease and for those that are not at risk of cardiovascular disease long term. And finally, secondary prevention with cardiovascular exercise, endurance training, as well as risk factor modification are super helpful for the long-term prognosis for these patients. Thank you.